Good morning, everyone. I have the pleasure of introducing our speaker today, Dr. Allison Hong. And I've known Allison since I started here at UCSF over 10 years ago, and she's been a wonderful mentor, teacher, colleague, collaborator, all those things. Allison is a UCSF lifer, so she did medical school, residency, and also got her master's here and has been here for her entire career. She's a professor of medicine. She also has appointments in urology and epi biostats. She's the director of research for the Department of Internal Medicine, the director of the UCS Women's Health Clinical Research Center. She directs NIH-funded mentorship programs that some of us in this room have participated in, the STAR program and the EuroEpi K-12 program. She's here to talk to us today about what she's passionate about, one of her many passions, urinary incontinence in older adults. And I'm thrilled to have her with us today. Welcome.
Thank you for that introduction. So it's a pleasure to be with you today. Although I wish, we had a larger room and that my slides, could be a little bigger, but we'll get by. So as you've just heard, I'm not a urologist or any kind of clinical specialist who focus exclusively on the lower urinary tract. I'm a general internal medicine physician. So I see patients across the adult age range for all kinds of health problems in the UCSF general medicine practice. Now, my research focuses on genitourinary health in older women, including issues like urinary incontinence and overactive bladder, genitourinary syndrome of menopause that disproportionately affect older women in the community. But I naturally view these issues from the perspective of generalist care. My research is influenced by my experiences trying to evaluate and manage these conditions among older women who are also presenting with all sorts of other competing health problems, who struggle, I think, sometimes to navigate our complicated bureaucratic healthcare system, and who complain sometimes, right, that the treatment options available to them, that they're not more effective, that they're not better tolerated, that they're not more accessible. So, conditions like urinary incontinence are incredibly common, but so many older women go untreated or maybe mistreated for years, right? And maybe it's not that surprising, right? The treatment options we have, they may focus a little too narrowly on single organ system mechanisms of disease. They may not address the overlap between lower urinary tract syndromes and other kinds of conditions that are common in aging. They rely maybe too much on costly, intensive one-on-one visits with specialists who just simply aren't in big enough supply, right, to meet the needs of all the people in the community who are trying to be served. So I have no conflicts of interest about this presentation, although sometimes I really wish I did. Okay. But today I just want to talk a little bit about some of the multifactorial contributors to common lower urinary tract syndromes in older women. Just discuss a little bit, what are some of the shortcomings of our current clinical approaches to managing these conditions, and try and weave in some of the work that my research team at UCSF and also other institutions has been spearheading to try and investigate other integrative, complementary, even alternative treatment strategies, sort of in an effort to figure out how can we try to manage these conditions that in a way that reflects their kind of population level burden. All right, so let's start with urinary incontinence. Many of my general medicine colleagues are surprised to hear how common incontinence is in midlife and older women. But I think the nice thing about this audience is that you probably know, really, over a quarter of women aged 40 and older, maybe up to half of women over age 65 in the US experience involuntary leakage of urine. And this isn't just, the proportion that have ever had incontinence or have it every once in a long while. It's the proportion who have leakage on an ongoing basis, at least once a week. So, this is a problem. Urinary incontinence has been linked to all kinds of bad things, to depression and social isolation, physical inactivity, functional decline, even falls and fractures. Although you could argue that these things aren't just the consequence of incontinence, some of them may also be contributors to incontinence. These relationships are complicated. And for many older women living in the community, incontinence is the factor that leads them to lose their independence. It's the straw that breaks the back of caregivers. It's a reason that people transition from living at home to entering long-term care facilities. So, we're accustomed to sort of traditional taxonomy of urinary incontinence that includes a couple main clinical types. We think about stress incontinence that is maybe mainly due to sort of a deficit or weakness of the pelvic floor in women, urgency incontinence related to overactivity of the detrusor or something abnormal about bladder sensation that's triggering detrusor contractions. Overflow incontinence, we think that the bladder outlet is obstructed or the bladder muscle simply isn't contracting the way it should. So sorry, I speak to generalist audiences where I have to explain every type of incontinence. I realize that this is old hat for you. We recognize that the phenomenon of functional incontinence where patients simply can't get to the bathroom or simply can't recognize that they need to urinate, because of advanced physical or cognitive impairment. But overall, we have a bladder-centric approach to thinking about incontinence, where we think about what's the deficit or problem with the bladder or the pelvic floor supporting the bladder, and that's how we think about treatment in most part. We do recognize that in older women, more complex female patients, bladder control problems aren't necessarily caused by just one single isolated physiologic or anatomic defect in the urinary tract. We recognize on some level, it's more multifactorial in origin. It's about the interaction between the lower urinary tract and other systemic factors, other contextual factors. It's not just that, these women have more weakness of the pelvic floor and more autonomic nervous system instability, leading to more sort of overactivity of their bladder. And, maybe they have more abdominal weight and obesity that's pressing on the bladder. And overall, their physical function decline is contributing. Their body doesn't handle fluid the same way. So it's not even just one of these, right? It's all these things simultaneously. And that makes treatment very hard, actually. It's much easier to treat things when we think there is one single defect that we can target than if we got 20 things going on and we can't even think about how to go about trying to tackle all these. So, in epidemiologic studies, we see compelling associations between urinary incontinence and other forms of functional decline in older adults. And that's true even when functional decline isn't that advanced. So if we think of just older women living in the community who are relatively free of disability, incontinence is more common in those who have, globally decreased skeletal muscle strength and function. And Susskind, among others, has, led analyses showing, prospective decline or worsening of skeletal muscle function older age. It's associated with both prevalent and worsening incontinence. There's evidence that sort of abnormalities in autonomic nervous system function that go along with physical function decline, and also mental and psychological function, that these are associated with some kinds of incontinence. So we see this on observational level. It's hard though. We haven't had good ways of trying to harness it to address treatment needs. So. Now, a lot of studies have shown that less than half of women with ongoing incontinence report receiving any kind of clinical treatment. I became aware of this early in my internal medicine training. As an intern, I inherited a primary care panel from a departing resident. It happened to be predominantly Chinese American and predominantly female patients. And I had multiple experiences where my patient would come to visit and I would dutifully do this sort of agenda setting. What do you want to talk about today? What's your priority? And they would say nothing. And I would get through my whole list of, your vaccinations. Let's talk about your diabetes. Let's get a thing. And it was only the end of the visit when I thought I was done and I was ready to walk out of the room, right, that my patient whips out a prescription, for pads or diapers or pull-ups and asks me to sign it. And I have to say, this is the way I think a lot of primary care doctors, internal medicines, discover that their patients have incontinence, is the sort of whipping out the prescription at the end of the visit. And I think at the time I thought like, oh, I've discovered this unique Chinese American problem. Like Chinese American women have a disproportionate amount of continence, but they can't talk about it with their healthcare providers, so nobody knows. But as I'm sure you all know, it's not a uniquely Chinese American problem, right? Like women of all racial and ethnic backgrounds have high rates of incontinence, and incontinence is sort of underdiagnosed and undertreated in all of them. And in a sort of analysis that I did later in the Kaiser Northern California system, looking at midlife and older women with at least weekly incontinence, as you can see, only 41% of the women who reported weekly ongoing continence said they had ever discussed their symptoms with a healthcare provider, and it might have been only like 22% who had engaged in treatment. So why is this? One reason maybe the stigma associated with incontinence. In Western society, we sometimes think of incontinence as more of a social problem than a medical disease. We associate incontinence with self-neglect, uncleanliness, poor self-discipline. Even the word incontinence, right, is used also for to talk about sexual promiscuity. Many older adults associate incontinence with sexual behavior, and so it's not so surprising that many people, their families, their caregivers, feel like they need to manage this problem in secrecy. Right, the shame associated with incontinence has been reported in studies to be higher than that of depression, of cancer. And then, you could argue that although clinical treatments for incontinence are available, many of them have important limitations. So, first-line treatment for all kinds of incontinence in women, at least according to sort of older guidelines, is supposed to be, behavioral strategies, bladder training, pelvic floor exercises. These can be very helpful, but a lot of women, patients of all kinds, who try to practice these after sort of routine teaching by general practitioners, they can't figure out how to do it. Or if they can figure out, they can't keep it up over time. It can be improved if they work sort of one-on-one with, say, pelvic floor rehabilitation therapists, but those kinds of therapists are in a bit short supply, right? And that kind of intensive, repeated visits one-on-one, it can be costly, it can be burdensome. Bladder medications are modestly helpful in improving some kinds of incontinence, but they have multiple potential side effects. Many people who try them discontinue them in only 6 months, and on top of it, we're now worried about even more serious consequences of some kinds of anticholinergic medications. Could they be associated with cognitive impairment? Could they be associated with dementia? And then there are obviously surgical procedures, other procedural treatments. For some women, they can be a lifesaver. There are many women who just will not consider them, even especially older women. They worry about the complications. They worry about the additional costs. They worry about prolonged recovery time. And then, most of these treatments, we'll say, even ones that we think are safer, they are sort of focused on one organ-specific physiological contributor of incontinence, one physiologic target at a time. Even though our kind of model of multifactorial syndrome of incontinence sort of suggests that a lot of people need strategies that can address multiple aging-related contributors simultaneously. And then, as we said, most of these treatments do rely on kind of repeated visits, one-on-one with specialized practitioners. And they're just not enough of those practitioners to meet the needs of all the women who have incontinence. I mean, it's not a urology specific or urogyne specific problem. It's our Western model of care, right? It focuses on intensive visits with specialists. If people have acute or rare problems, this model ensures that people get the most individually tailored, specialized treatment. But there will never be enough urologists, urogynecologists, pelvic floor specialists to meet the needs of all the older women with incontinence who need care. It will never happen. So it's arguable that we kind of need a different treatment paradigm for incontinence that's more appropriate to its population level impact. Earlier on in my career training, I was interested in improving access to treatment in primary care, and I still am to some extent, right? I was looking into streamlined algorithms for diagnosing and treating incontinence in primary care, and can we look at the kinds of diagnostic tests that are recommended, and can we do away with some of them? And what if we use simplified measures like the 3 incontinence questions or 3 IQ to just spearhead treatments quickly? At the same time, though, it's interesting. A lot of women with incontinence don't really want to see clinicians at all, right? They are actually going to complementary and alternative providers for their urinary symptoms, for their pelvic floor symptoms. They're going to acupuncturists and chiropractors and naturopaths. They're trying Chinese medicines and herbal medicines and vitamins and minerals. Sadly, at the moment, there's little or no evidence that most of these strategies are effective. But I think it's telling, like when a large proportion of the general patient population is going outside of the traditional healthcare system, it's a sign that they perceive that the traditional healthcare system is failing them, right? And also you could argue when a large number of people are using certain kinds of treatment strategies or self-management in communities, then it's, we have an obligation to try and study them. We have to understand what's going to happen. Are people getting benefit? Are they hurting themselves? Right? What does it mean? So now I'm going to turn to one complementary set of physical and mental practices that has been recommended for women with incontinence, which is pelvic floor yoga. So some of you may be thinking this sounds crazy, really, like my older frail woman with incontinence, she should be practicing downward facing dog, and that's what's going to, solve her incontinence. So there are reasons, though, if we think about this kind of multifactorial aging-related model of incontinence, that we think that pelvic floor yoga or the right kind of yoga could be helpful. So firstly, broadly, hatha yoga, the major branch of yoga that involves practicing physical postures, asanas, this is practiced by a lot of people just to improve general muscle strength and conditioning. Right? It could be a way that you could prevent or improve physical function decline as a modifiable risk factor for incontinence in older women. Certain kinds of yoga, for example, Iyengar yoga, they put a lot of emphasis on awareness of specific bodily structures during the practice of poses. So it can be used, for example, to help people think about and become more aware of their pelvic floor muscles when they're practicing poses. And in that way, tackle one of the major problems with, say, pelvic floor rehabilitation, which is that like people can't seem to isolate their pelvic floor muscles. They don't even know what they should be contracting or squeezing. You could almost think of pelvic floor yoga as a kind of complementary substitute for pelvic floor rehabilitation therapy. Yoga has been suggested to improve general cardiac autonomic function and then improve the restorative aspects of yoga to improve perceived stress, to perceive anxiety, which have also been identified as potential risk factors for certain kinds of incontinence, for example, more urgency type overactive bladder related incontinence. Yeah. And then there it is that yoga, in contrast to our traditional clinical treatments, right? It's not dependent on visits with clinical specialists. It's possible to deliver in the community, in senior centers, in yoga studios, in community centers. It can be taught in groups, so potentially more efficient to deliver a lot more people in the community. And it's easier to frame as a wellness activity, right? So it has positive connotations for health for other reasons. And there's a reason to think that like a lot of people who would not ever want to mention to their friends or relatives that they are going to their pelvic rehab, therapy session for their incontinence are willing to say, oh yeah, I'm going for my yoga for pelvic health class, right? It's something, it can normalize actually a need and a type of activity that can be beneficial. So there are a whole bunch of yoga classes and workshops and series and books out there for incontinence and for pelvic health. If you do an internet search, you'll find plenty of images and advertisements. Until recently, none of these yoga practices, though, were supported by any evidence of efficacy, certainly not rigorous evidence. And a lot of the advertisements also, they featured young women, healthy women, athletic women, usually also white women. Whereas, of course, many women with incontinence, they have multiple chronic conditions, they're overweight or obese, they're older, frailer, more susceptible to injury. So it's reasonable to say, well, gosh, not only do I wonder whether pelvic yoga is helpful for incontinence, but it seems a little implausible to me. Can older women who are characteristic of the patients I see, is it even safe or reasonable for them to practice yoga? So this was inspiration for some studies that our research group spearheaded to kind of develop, test, evaluate a therapeutic pelvic yoga program for urinary incontinence in ambulatory older women. This is work that involved like partnerships with integrative medicine folks and urogynecology and geriatrics, yoga consultants in the community, physical therapists. We started with just a small single randomized trial, less than 24 women. They were randomly assigned to either a 6-week pelvic yoga program, or what was essentially a waitlist program. You don't get any yoga instruction for 6 weeks, but at the end of 6 weeks, we'll give you gift, certificates for yoga classes in the community. Women also did receive like simple written, information about first-line self-management strategies, the kind of thing that we would hand out as a pamphlet in primary care. So, we focused on midlife and older women who had at least daily incontinence that we could sort of describe in terms of clinical type. They had to be willing to temporarily forego traditional clinical treatment, so they couldn't be simultaneously taking a medication, going to pelvic floor rehab, getting a procedure. Right? We did exclude women with more complicated urologic histories that we might say, oh, you kind of need to see a specialist first. The women did have to be ambulatory. They had to be able to walk slowly, but they had to be able to walk unassisted. But they couldn't already be engaged in yoga. Like we wanted a naive to yoga population, not the disproportionate older women who were already like very heavily engaged in yoga. So the yoga program focused on just standard hatha yoga poses, practiced everywhere. There was more emphasis on kind of precise postural alignment and body awareness during the practice of poses. Similar to Iyengar-informed yoga at large, the program used yoga props like flops and straps and bolsters to try and decrease the risk of injury and accommodate women with lower flexibility. It was a program developed through a panel of yoga expert consultants in sort of twice weekly group classes. Participants were instructed by a yoga teacher who'd undergone study-specific training. And then outside of class, women were asked to practice yoga individually using a manual that included detailed instructions and pictures for each pose. And then instruction in both the group classes and in the manual included tips for performing the poses safely and comfortably, including strategies for adapting the poses using props. Both the group instruction and individual practice also focused on strategies for tailoring poses to improve pelvic floor awareness. And all class materials were designed to be appropriate for welcoming for women across a range of ages and body types and ethnic backgrounds. So this is actually a picture of my mother. In the early pilot, we realized we don't have pictures of any Asian women, and that's preposterous because there's so many Asian women in the Northern California area. And I reached out to my parents and said, could you take a picture of mom, in the living room? And bless her heart, my mother, who has never practiced yoga in her life, agreed to be photographed in like long underwear, doing a simple yoga pose. Maybe it's a testimony to what a traditional Chinese American mother will do to further her daughter's career, right? So results demonstrate women were able to learn to practice yoga and adhere to the program over 6 weeks. All of the participants attended at least 11 out of the 12 yoga classes. The majority attended all of the classes. At the end of the program, they said they were all at least like moderately self-confident in their ability to practice these poses. And then, based on voiding diaries, detailed voiding diaries in which they recorded every time they leaked urine or used the bathroom, improvement in incontinence frequency looked quite substantial in the pelvic yoga group. So, over 6 weeks, the pelvic yoga group reported an average decrease of more than 13 episodes a week, starting out around like 20 episodes a week at the beginning. So that was, good 2/3 reduction. Whereas the waitlist control group over that 6 weeks, it was only about a 13% reduction. So our yoga consultants were ecstatic, and they would have been happy for us to just stop there. But of course, we couldn't stop there. I mean, this was a small study. It was a single site study. It really only involved one yoga instructor. It involved a relatively weak study design, a waitlist control where you could almost say that the comparison group is almost primed to expect that things should go badly for them. The wonderful yoga classes are being withheld from them until the end. So we felt we needed to study more. And on top of it, for an intervention like yoga, you could argue it's not just that we want to know, is it beneficial? We want to know if any benefits are really unique and specific to yoga, right? Like, do you actually have to do yoga, or could you do something else? Like maybe these women who were not engaged in any kind of physical activity at the beginning just needed to exercise more broadly. So we went on to 2 more trials. conducted, in more locations in Northern California. First, another feasibility trial supported by NCCIH, then a full-scale efficacy trial supported by the NIDK's urology branch. And here, women were randomly assigned to either a pelvic yoga program, now 3 months long, or what we call the general physical conditioning program. So this involved time equivalent group classes and directed practice of non-specific skeletal muscle stretching and strengthening exercises. And then again, like all the women received some basic written information about first-line behavioral self-management strategies for incontinence, but no additional teaching in that. So just briefly, this physical conditioning program, it was designed by our physical therapist consultants. It was led by either physical therapists or personal trainers in the classes. It was a pretty robust intervention in its own right, like twice weekly classes, self-directed practice, like props, manuals for people to practice at home. Similarly, like tips on performing the exercises safely, pictures to try and be welcoming to people from a range of backgrounds and body types and fitness levels. I'll say when we started the most recent trial, it was right before the pandemic, and we were starting out with all like in-person classes in yoga studios, fitness studios, and then in the spring of 2020, as you know, shelter-in-place orders were issued. It happened to be a particularly annoying time for the trial. Because of the group classes in this study, we had to sort of recruit people for several months, and then we would just like randomize a whole wave or cohort of participants across multiple locations en masse, so they could start their classes at around the same time. If that makes any sense. So we'd just gone through months of screening, and then we had just randomized women across 3 different locations, and then the shelter-in-place orders fell. And as many of you know, once randomized, always analyzed. Like we cannot drop people who are randomized. We either had to accept massive dropout, which would have totally compromised the study, or do what we did do, which was we converted to video conference instruction. So all instruction then was live, synchronous, but over video conference, which was very hard at first. I have to say, we did not have a chance to think, about this carefully and plan it. We had participants as old as 90 in our study, and some of them like had not used Zoom before. I think one of the things we take biggest credit for is we taught a lot of older women to use Zoom for the first time, and now they use it a lot. So this was challenging, and we worried whether this was going to be safe, right? We're going to injure people. We can't lay hands on people. This is So, of course, like a lot of people, we had these optimistic ideas like, oh, we'll convert for a while, but we'll go back in person soon. But in this study focusing on older adults, there was never a point where we felt like we were really safe to go back to recollect in person in Zoom, or that the participants would be willing to tolerate it, many of them. So in the end, 2/3 of participants who were randomized end up getting their instruction primarily by Zoom, just mentioned. But follow-up with the participants wasn't bad. Not that many people dropped out. Most people were able to stick with it. So just say, we had a range of ages in the participants at the end, age 45 to 90. Good representation, I think, of women from ethnic minority backgrounds, given the stereotype of yoga as sort of activity for affluent white women. Women had an average of 3.4 incontinence episodes per day at baseline. Most of them had incontinence for at least 5 years. That almost all of them had incontinence for at least a year before they entered the study. Concerns about safety, I think maybe weren't totally unwarranted. More just that like we had a lot of unexpected events that went along the way. I remember getting a page from one of my clinical research coordinators, like, patient tripped over a yoga prop, fracture. And I called her in a panic. I said, if we cause even one fracture, this is the end of the study. Doesn't matter if we cure incontinence for everybody, we can't cause fractures. Fortunately, it was not a new fracture. And also was not something that happened in the middle of a yoga class or during yoga practice. One of our participants, she left her yoga blocks and things spread on the floor. She tripped over one at a time when she was walking across the room. She like sort of had a flare up of pain in the area of an old fracture, frankly, not a no new fracture. But it shows the complexity actually of trying to sort of create and administer these kinds of programs in complex older patients. So, when I order like a home safety evaluation for my older patients who've had a history of falls or at risk of falls, one of the things that the occupational home therapist does is like, on their checklist is like clutter in the home, get people to put their stuff away, power cords, rugs, what are the trip and fall hazards? And so we were like increasing people's fall hazards by we had to like have new instructions. You must put your props away. Don't leave them out where you could trip and fall on them. So just one example. Then, the Zoom-based approach, like it gives a lot of insight into people's homes. Like our yoga teachers would call us like, I feel like the women in my class are hoarders. They're trying to practice yoga in these like closet-like spaces in their home that's packed full of things. It's true. Like we like the idea of a community-based intervention, but that means that people are trying to practice and learn. They're trying to turn their own homes and communities into yoga studios, which they're not necessarily intended for, right? Sometimes our participants couldn't get privacy. That we'd have older women who were the primary caregivers for their spouses with dementia. Spouses would like interject or ramble or say inappropriate things in the background in classes. So this is the reality, right, of trying to deliver interventions, complex ones also at home. So, based on voiding diaries that were abstracted by blinded analysts, total incontinence frequency again decreased to close to 2/3 in the yoga group, but it also decreased by more than 50% in the physical conditioning group over 3 months. So average improvement in both groups, was greater than the 50% threshold that's been sometimes described as the minimum clinically important difference for people who start out with daily incontinence. And when we look in like mixed models, controlling for clinical site, baseline incontinence frequency, predominant clinical type of continence at baseline, and the clustering of the group classes and which instructor people had and everything like that, the differences between the groups didn't meet our pre-specified threshold for significance. Urgency incontinence frequency may be improved a little bit more in the yoga group than the physical conditioning group. Reductions in stress type incontinence were very similar between groups. And then, if we look at like standard questionnaires like the Urinary Distress Inventory 6 and the Incontinence Impact Questionnaire, that sort of thing, there are modestly greater improvements with pelvic yoga on the UDI-6, but not with other measures, right? So I'll say, on the one hand, ambulatory women with daily urinary incontinence across the aging spectrum, they were able to learn to practice pelvic yoga safely over time. Both programs were associated with a greater than 50% average decrease in incontinence frequency. But actually, I'm not sure this study says that pelvic yoga is superior to general physical exercise in reducing clinically important incontinence in older ambulatory women. Strictly speaking of the study, we didn't compare yoga to nothing at all. So I don't have definitive proof here that yoga is better than doing nothing, remaining sedentary, no activity. But if it does have benefits, it's arguable that they're shared to at least a substantial amount with other kinds of physical activity among older incontinent women who are sedentary at baseline. All right, I'm going to talk about one other study, another line of research that this one focuses on sort of the complicated and bidirectional relationships between sleep and nocturnal urinary symptoms in older women with overactive bladder syndrome, or OAB. So, OAB defined by recurrent strong urges to urinate that send people rushing to the bathroom or leaking urine. One of the main ways in which OAB is thought to be, problematic to decrease quality of life is by disrupting sleep. Right? So over 40% of patients with OAB report nocturnal urges to urinate associated with waking up and going to the bathroom. Many patients with OAB say, oh, I don't mind, when I have an urge in the daytime and I just go to the bathroom. It really bothers me when I have to get up at night. Like nocturia, right, is one of the most frustrating symptoms for folks. But it's a bit complicated, right? Among older adults, a lot of things can affect sleep continuity, sleep disruption, age-related changes in circadian rhythms and medications that people are taking, other physical health conditions, other factors that affect how the body handles fluid in the day and night. On the one hand, if somebody has OAB, they can have an urge to urinate that wakes them up, then have to go to the bathroom, then have difficulty getting back to sleep and be frustrated. On the other hand, maybe some patients just have sort of a heightened underlying physiological arousal or sensory arousal. So they're more susceptible to being woken up to urges to urinate. Some sort of bladder contraction that nobody else would be bothered by, would sleep right through, they instead wake up. And then, once they have that stimulus, it becomes a reason why they stay awake. So it's kind of hard. Like if people get up for another reason, also they may end up urinating and stay awake afterwards. It's very hard, right, to figure out like is the bladder the primary cause of sleep problems? Is poor underlying sleep quality the reason that people are getting up to urinate at night, or more likely like both, right? Sorry. Oh, there we go. Okay. And then let's see, both OAB and sort of sleep disorders are often associated with high levels of perceived stress and anxiety, associated autonomic nervous system function that are connected to anxiety disorders. So for example, we have epidemiologic studies that show women with high levels of anxiety, they're at increased risk of developing new onset overactive bladder, even if they have no bladder symptoms at baseline. In physiologic studies, sort of patients with OAB and those with insomnia, they also have sort of abnormalities in heart rate variability that point to sort of altered resting or stress-based parasympathetic function or sympathetic function. So there's been a fair amount of interest in trying to identify interventions that decrease anxiety and stress and improve autonomic balance as a way of improving overactive bladder, improving associated sleep dysfunction, both combined. Some of these have included both the cognitive behavioral therapy for women with overactive bladder, which at least one recent trial was found to improve overactive bladder-related quality of life. Hypnotherapy that has been explored. There was a trial not that long ago. Hypnotherapy was non-inferior to bladder medication in improving overactive bladder outcomes in patients. So there is evidence that approaches that are sort of targeting the mind-body connection can be effective. That said, again, we're talking about psychological approaches that, again, rely on intensive one-on-one visits with specially trained practitioners. And there's just a limit to how many of people that there are ever going to be and how well they're going to serve the needs of the population. So I'll say, my team sort of became interested in one type of behavioral intervention that was potentially more scalable, generalizable. So this technique is called slow-paced respiration. It's a technique of slowing the respiratory rate, prolonging the expiratory phase of breathing to promote relaxation, to improve autonomic nervous system balance. It's been explored as a behavioral treatment for a lot of different psychological conditions: social anxiety, panic attacks, post-traumatic stress disorder. In a way, you can think of like our traditional urge suppression techniques for overactive bladder as being related, because we often tell patients, okay, you feel that urge to urinate, don't rush to the bathroom, stop, take slow, deep breaths, try and overcome that urge sensation. We think of it, though, mostly as a kind of ad hoc response to urgency in the moment, whereas paced respiration, slow paced respiration for other chronic diseases, it's really been explored as a kind of regular practice to try to reduce the underlying susceptibility to the problem in the first place. And there's many ways in which people can practice slow paced respiration, but I'll say one is, there are portable devices. There's also now like smartphone, connected apps, of course, but at the time we were focusing on Respirate, which is a small portable guided breathing device. It includes like a little belt-like sensor that sort of measures inspiration and expiration. It plays musical tones that are synchronized to the inspiration, expiration. It's a biofeedback device, basically. And over time, it gradually elongates and changes those tones so that the user is guided in breathing more slowly, prolonging the expiratory phase of breathing. This device is actually FDA approved for the treatment of hypertension in adults. Evidence that using it on a regular basis decreases blood pressure. And so the device manufacturers, the program manufacturers also, they had more recently converted it to a program that was meant to promote sleep, so called To Breathe. It was being advertised like this program now in a mobile app platform. It can be connected to a Pili-based speaker, help reduce and improve sleep naturally. And the same kinds of concerns that are being brought up for overactive bladder medications and their potential harms in older adults. These kind of concerns come up for sleep medications in older adults. So great interest in finding behavioral approaches to improve not only overactive bladder nocturia but also overall sleep. So, this was part of the inspiration for another series of studies, culminating in the Controlling Urgency with Relaxation Exercises trial. And we're trying to figure out, Can device-guided slow respiration improve overactive bladder symptoms by improving perceived stress and autonomic function? Can we look at the directions of sleep problems and bladder symptoms at night in this population? Does slow-paced respiration improve sleep outcomes in women with overactive bladder? This again was a randomized parallel group trial. And again, we were trying to get at like, what are the unique and specific effects of this intervention? So participants were either randomized to practice slow-paced respiration for at least 15 minutes a day, ideally longer, for over 3 months, or to use sort of an equivalent time. Like we basically arranged to reprogram the respirate devices so that instead of guiding people and slowing their breathing, it just played some non-rhythmic musical tones and monitored their spontaneous breathing. And again, basic written first-line behavioral information given to participants, but no additional teaching at the same time. So, the focus here was on ambulatory community dwelling women, frequent, sudden or strong urges to urinate, willing to temporarily forego standard clinical treatments for OAB, not too complicated in terms of their urologic history, and then also they couldn't have chronic breathing or respiratory problems that meant they couldn't practice slow-paced respiration. And they filled out diaries and questionnaires and sleep diaries and sleep questionnaires, and including questionnaires about their mood. They did some sort of heart rate variability and cardiac impedance measures, looking at their cardiac autonomic function. And so about 160 women were eventually randomized, and half to the paced respiration group and half to the control group, with pretty good follow-up in both of the groups. And again, so, mean age in the low 60s, most ethnically diverse, with a lot of urgency episodes per day, and a fair amount of sleep problems at night if we go by their Pittsburgh Sleep Quality Index global scores that were definitely above the threshold on average of clinically meaningful sleep disruption. And a lot of women were getting up at night, right? And getting up at night to use the bathroom also. So when we looked at the participants' sleep diaries, it looked like many, but not all nocturnal awakenings were attributable to going to getting to use the bathroom. So this is a table. It presents the percentage of participants reporting like 0 awakenings, 1 to 2, 2 to 3 awakenings at night. And then among the people who are reporting any awakening on average at night, it's looking at the percentage who indicated that they were getting up to use the bathroom versus like getting up for noise or for partner issues, for pain or discomfort, this thing. And so you can see, nearly 90% of participants reported awakening at least once a night. Of the participants with at least one nighttime awakening, the majority did attribute at least half of their awakenings to needing to use the bathroom. But then, the other very substantial proportion, they were being awakened for other reasons. They did not perceive that the bladder was the issue that was breaking them up. And so, looking at average wakefulness after sleep onset, average sleep quality, average sleep time at baseline, and then how that differs depending on the number of nocturnal bladder symptoms episodes that participants were having, you can see, if participants had more voiding or incontinence episode at night, they did seem to have more wakefulness after sleep onset. But interesting, global sleep quality score did not differ that much based on how many times people were getting up to use the bathroom. People just sometimes had poor sleep for other reasons. Underlying sleep quality may have been more the problem than their bladder symptoms. And looking over the 3 months of the intervention period, so perceived stress, anxiety improved in both groups. Perceived stress did improve somewhat more among the paced respiration group than the music listening control group. This didn't translate, though, I have to say, into substantial differences in people's underlying cardiac autonomic function. And then when it comes to nocturnal urinary symptoms, so frequency of nocturnal urinary symptoms did improve in both groups. Sleep quality improved in both groups, but the paced respiration group was not sufficiently or substantially better than the music listening group in terms of improvement in nocturnal urinary symptoms. So I have to say again, self-reported sleep dysfunction in this sample of women enrolled in a randomized trial paced respiration, sleep dysfunction was common. Women did attribute some of their nocturnal wakings to use in the bathroom, but this was not actually the overwhelming cause of problems with sleep quality. Greater frequency of nocturnal voiding was associated with more wakefulness after sleep onset. But from a treatment perspective, while we saw modest improvements in nocturnal voiding frequency, global sleep quality, perceived stress, our results did not confirm that slow-paced respiration should be recommended as a treatment for insomnia or for nocturnal bladder symptoms, above and beyond, let's say, spending a similar amount of time a day listening to relaxing music. So I thank you. I have a lot of people to thank for their contributing to the study. Collaborators, the NIH institutes and centers that contributed to work along the way, the participants in the study who spent all their time practicing yoga or doing exercise or practicing paced respiration. I just want to say that I've reported to you some of the main outcomes for these two trials. We still have quite a bit of additional data. And if there's folks who are interested in exploring more autonomic function data in relation to urinary tract symptoms or in relation to psychological function, please feel free to reach out. I do. And we have a number of other trials going on that include urinary symptom measures or urinary function measures, trials that are trying to compare, for example, the implications of anti-muscarinic versus beta-3 agonist medication versus no medication among older adults, older women with urgency predominant continence, trials that are focused on pelvic health conditions like uterine fibroids, but also looking at implications for urinary symptom measures, integrated behavioral treatment for combined nocturia and insomnia in older adults. And we are now in the midst of trying to start up and launch a new yoga-related trial, a national all-remote trial of trauma-informed pelvic yoga or physical conditioning for women with chronic pelvic pain, for which we want to recruit women across the contiguous United States. That's something where we have figured out a fair number of self-report measures. We have not actually incorporated yet any physiologic measures, but there might be an opportunity to do that and do it in what eventually will hopefully be a national sample. So just want to encourage folks to reach out if they are interested in collaborating or have things to suggest.